Thank you for inviting me to be here to speak. My name is Gerard Kottenbrock. I'm a clinical social worker with a specialty in mental health and addiction. I work at the mental health service line at the Fargo VA. So, any veterans in the crowd, please stand up. Please stand up. Thank you for all you do. Today we're going to define co-occurring next slide. So first I want to thank Allison, who's going to be my part-time narrator. Thank you very much, Allison. Round of applause in advance. Yay! She's a little freaked out about it. So today we're going to define co-occurring disorders. We're going to identify risk factors and best practices. To my narrator.
Of mental illness, but is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make contribution to his or her community.
So mental health is the ability to learn, feel, express, and manage the myriad of emotions that we human beings have. Forming relationships is the glue that holds it all together. So the opposite of mental health, to put it bluntly, is mental illness. So mental health disorders are diagnosed using symptom criteria from the, okay, I'm going to get this right, Statistical Manual of Mental Health Disorders, 5th edition. And so you need to remember that mental illness occurs on a continuum. So it can include like a single episode of depression, or it can include recurrent major depression. Let's define it.
Serious mental illness, or SMI, is defined by someone over 18 having within the past year a diagnosable mental behavior or emotional disorder that causes serious functional impairment that substantially interferes with or limits one or more major life activity.
So mental health disorders are pretty common in the United States. So 1 in 50 or 50% of people lifetime will experience a mental health disorder. So half of us are going to experience a mental health disorder. So raise your hand. No, just kidding. So again, some of these statistics you already heard, but 1 in 5 people in the United States in 2020 were diagnosed with at least one mental health disorder, and 1 in 20 with serious mental illness. So, and I think this is interesting, 50% of all lifetime mental illnesses start at age 14 and 75% by age 24. So there are groups that are at higher risk for developing a mental health disorder. So women, people reporting more than one race, homeless populations, people who are in jails and prisons, and those identified as LGBTQ, and someone earlier talked all about that, so thank you. So let's turn our attention to addiction and substance use disorders. Take it away, Alice.
Addiction is treatable. Chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases.
Thank you. So, I better do this. Okay. No. I've really been messing up, haven't I? All right. So, first and foremost, substance use disorders are brain-based diseases based on chemistry, biology, and neurobiology. So they're primary illnesses. They are not caused by something else. They're disease in and of themselves with identifiable symptoms that progress over time. They're chronic, meaning once you cross that line, you can't go back. You can't, once you're in recovery, you can't have a glass of wine in the evenings or shoot a little heroin on the weekend, you know? Once you're there, you're there. So left untreated, they grow progressively worse over time. There's no cure. So remission requires complete abstinence from all mood-altering chemicals. So left untreated, people die from this disease, either by accident, deterioration in their health, or suicide. So a lot of you have kind of talked about these statistics. So, so maybe it's a reinforcement of what we already know. So 10% of the people in the population have substance use disorders, and researchers think that it's a lot more than that because it's underreported, and they're thinking maybe 15 to 20% of people have substance use disorders. So alcohol is the most abused drug in America. It's also advertised as the most life-enhancing. So of the 21 million people diagnosed with substance use disorders, 15.1% have an alcohol, or 15.1 million have an alcohol use disorder, and 7.4 have a drug use disorder. So again, something else I find interesting, 90% of those diagnosed with substance use disorders start before the age of 18. I'm sorry.
Is it not moving?
No, I just messed up.
You're doing great. Yeah.
Okay. Okay. I'm on track, which is good for me because that's not always the case. Allison, what's a co-occurring disorder? Well, I'll tell you what it is.
Yeah.
People with co-occurring disorders have at least one diagnosed mental illness and one diagnosed substance use disorder. So 2 or more mental health and substance abuse disorders develop independently but affect one another. So, but one does not cause the other. It's important to remember that. So in 2020, 6.7% of people in the United States had substance use co-occurring disorders. So co-occurring disorders are more severe and persistent than any single disorder. So mental health diagnoses most associated with co-occurring disorders, personality disorders, anxiety disorders, mood disorder, most common bipolar, that was mentioned earlier, psychotic disorders, particularly schizophrenia, and attention deficit hyperactivity disorders. So some groups are at higher risk. Men are more likely than women to develop a co-occurring disorder. Males 18 to 24 are at highest risk. Military veterans, those with severe and persistent mental illnesses, people who live in poverty, those diagnosed with head injuries, and people with serious comorbid health conditions. So the number one predictor of having a mental health or substance use disorder is genetics.
40 to 60% of individuals diagnosed with a substance use disorder are genetically predisposed. So genetic predisposition accounts for 20 to 75% of individuals who develop a mental health disorder.
So genes alone don't get you there. So if I have mental health genetics, let me say it again. If I have mental health genetics, they may not activate or be less severe if I have good protective factors. So if I'm genetically predisposed for a mental or substance abuse disorder, I actually have to use in order for that to kick in. Otherwise, it just doesn't happen. So the combination of the genetics and environmental problems is what turns genes on. So look at environmental stressors. This is a short list. We've talked about lots of others here, but history of trauma is strongly associated with developing a co-occurring disorder. Early adverse life experience, physical, emotional, sexual abuse, neglect, the list is long. So lack of supportive relationships, and I would say lack of intimate relationships. So people who are in jails and prisons, the homeless, lack of food and proper nutrition, someone talked about that earlier. Lack of affordable health care, Cora touched on that. And there's access issues. So you might live in a rural area and there's not a lot of doctors and stuff, or you might live in an urban area where there's poverty and that kind of, or where you live in an impoverished place. So there's not the infrastructure in place, nor the enough providers. So that's a big problem. So development plays a role. So disorders often surface in adolescence and young adulthood when our brain is just changing rapidly. So disorders often surface when the brain is naturally, let me say that again. Early exposure to mood-altering substances cause deficits in the brain, resulting in risk for mental illness. So early symptoms of mental health that go unrecognized or untreated can lead people to start using substances for relief, which is called, anyone? Self-medication, right? We've all self-medicated a bit. So prolonged stress is a factor. Somebody talked about that, so I'm going to give you the skinny on that. So prolonged environmental stress for any age group can cause genetic changes, contributing to the development of mental health or a substance use disorder. So stress hormones are released and cause changes throughout the body, and they trigger changes in DNA, and it changes gene expression. So I just thought that was very interesting. And again, it's a brain-based disease. I apologize, I'm behind here. I'm so excited that I just, So mental illness is one of the strongest predictors of suicide in the United States. Of the almost 45,000 suicides in 2020, 46% were diagnosed with a serious mental health disorder, and 90% showed mental health symptoms. So suicide risk is highest among individuals with bipolar disorder. We talked about that earlier, and other mood disorders, followed by schizophrenia and anxiety disorders. So those are at-risk diagnoses. So substance use disorders are among the most frequent mental health diagnoses when it comes to suicides. So a person with a substance disorder is 10 to 14 times at greater risk for death by suicide than the general population. So over 50% of all suicides are associated with substance use disorders. 25% commit suicide. So alcohol use, again, poses the greatest risk for suicide. 40 to 60% of people who died by suicide were intoxicated at the time of their death. I'm not being very good here with my power, with my keeping track. So somebody keep me honest. So people with co-occurring disorders are at highest risk for suicide than those with just a single disorder. And this is due to the synergistic relationship between the two disorders and the varied multiple symptoms that come with it. So people with co-occurring disorders are more likely to have medical and neurological comorbidities, increasing risk. Again, that was spoken about earlier. So pain disorders and traumatic brain injuries are at highest risk. So a history of trauma increases risk for those with co-occurring disorders versus those with just a single disorder. Got it. Or no, I don't got it. No, okay, all right. We just did this one, didn't we? Yes, we did. No, we didn't. If we didn't, I'm going to do it again. How's that sound? So people with co-occurring disorders are at highest risk for both contemplating and attempting suicide. Suicide, and again, this is very interesting. Suicides with co-occurring disorders exhibit a gene expression profile that's distinct from those who just have a single disorder or no disorder at all. So people diagnosed with alcohol use and mood disorder at highest risk for suicide, counting from 40 to 70% of all suicides. And again, those with bipolar are at the highest risk. So it's difficult to treat co-occurring disorders. People present with an array of complex symptoms, and symptoms of one disorder often mimic the other. So you have a late stage alcoholic that comes in and they are depressed and extremely anxious. So over time with sobriety, those mental health issues disappear. So someone presenting with a psychotic disorder could actually be suffering from late stage methamphetamine use disorder. So overlapping symptoms are difficult to unravel with co-occurring disorders. So it really takes time and patience to diagnose a co-occurring disorder versus just a single disorder. So post-acute withdrawal syndrome is a factor in recovery from addiction. So the symptoms began after acute withdrawal symptoms resolve. And it is a direct result of damage done to the brain over time due to use of substances. It can take from 6 months to 2 years for someone to fully heal, the brain to fully heal from a bout of addiction. So the brain's kind of striving for equilibrium, so symptoms can ebb and flow in intensity. And frequency, particularly early recovery. People talk about like, it's like riding a roller coaster. I'm up, I'm down, I'm in, I'm out. I don't know what to do. Post-acute withdrawal symptoms syndrome presents with a variety of symptoms. So, this is quite a list. The question is often posed, why don't they just quit? Take a look at that list. People quit using and they feel worse, initially they feel worse. So imagine if you woke up tomorrow just feeling half of those symptoms. Personally, I don't think I'd get out of bed forever. So these symptoms increase risk for relapse and suicide. So stigma is another major issue in terms of complexity. Allison's going to tell us what stigma is.
The term stigma represents the complex of attitudes, beliefs, behaviors, and structures that interact at different levels of society. So individuals, groups, organizations, and systems, and manifest in prejudicial attitudes about or discriminatory practices against people with mental and substance use disorders.
So stigma occurs when a person is defined by their illness rather than who they are as a human being. So the external experience of stigma includes stereotyping, negative attitudes, and discrimination among community members, family members, peers, and even professional providers. So eventually what happens with people, those stereotypes they begin to believe they begin to believe that those stereotypes are real. So those messages become internalized. So people believe that people may feel shame, guilt, remorse, weak-willed, no good, etc. They feel bad about who they are as a human being. So internalizing stigma leads to increased feelings of helplessness, hopelessness, and suicidality. So there's some difficulty in treating people with co-occurring disorders. Of the 14.2 million people with serious mental illness, 40% are not receiving any treatment. So 21 million Americans have a substance use disorder, and only 10% of those are getting treatment. Over 50% of people with co-occurring disorders are not receiving treatment for either condition. So only 18% of addiction programs and 9% of mental health treatment organizations are really equipped to treat co-occurring disorders. So what does effective treatment look like? So the best way to treat co-occurring disorders is concurrent, concurrent integrated programs are most effective. So both disorders are treated as primary and symptoms are addressed at the same time. So providers must have expertise in both substance use and mental health disorders. So they engage with consumers of mental health by bringing expertise for both disorders. So concurrent treatment also includes the recovery model of care. And so what is that, Allison?
The process of change to which individuals improve their health and wellness with a self-directed life and strive to reach their full potential.
Thank you. So it's person-centered and person-driven. So it respects self-determination for people to develop a plan with issues that are important to them. Oftentimes, providers say, oh, here's your problem, and never stop to ask, what do you think? So it really emphasizes changes people can make for themselves with the help of others, and it decreases the impact of the illness and actually helps to restore a meaningful life. So the interaction between the provider and consumer is mutually dynamic. So providers are tasked with engaging patients. So recovery does not necessarily guarantee a cure. Some people will always struggle with serious symptoms. So recovery is an ongoing dynamic process represented by the 10 components of the recovery wheel. SAMHSA actually put this out originally, and the one we have here is adopted by the VA. There's copies in the back if you would like them. There's also some stuff about stigma over there too. So recovery represents the whole person and all the issues that needed to be addressed in ongoing treatment and wellness. So it also addresses the dynamic and collaborative process between consumer and provider. So let's conclude with effective treatment principles in suicide prevention. So as we discussed earlier, a recovery perspective is the foundation of treatment for people with co-occurring disorders, as we discussed in the model of care. So you'll have people showing up feeling confused, defeated, helpless, hopeless, and suicidal. So engagement begins with the initiation of hope. So sometimes people need to go on our hope until they can get some of their own. Engagement includes authentic therapeutic rapport, authentic being the key word. So that's based on unconditional positive regard. My thing is, if you don't know what else to do, go back to Carl Rogers and Mr. Rogers. So that's my philosophy. So therapeutic rapport is based on unconditional positive regard, emphasizing patience, respect, empathy, and compassion. These things cannot be faked. These people have been through so many treatments and have had so many providers. In about 5 minutes, they're going to know if you're serious or not. So you can't fool folks who have long-term issues. So empathy is key. If a person believes they not only have been heard, but understood on a deeply personal level, trust and mutuality will follow in the therapeutic relationship. So consumers present with multiple untreated disorders and the ensuing consequences. So we could list 100 of them. You guys, homeless, incarceration, those kinds of things. So these real-life problems need to be addressed first in a practical way before treatment can really begin. So plans to deal with cognitive and functional deficits often start with inpatient treatment to stabilize acute mental health and detox symptoms. So following the acute phase, many people continue with cognitive impairment. So stage-wise treatment helps in the next phase of recovery. A stage-wise approach offers multiple treatment formats and therapies at every stage of readiness and at all points of engagement in treatment. So it offers multiple interventions versus a one-size-fits-all type of treatment, and that is so key. So the stages of change model is kind of a component of stage-wise treatment. So a lot of you are familiar with that. So the stages of change are dynamic. People go up and down until they reach a level of wellness, but they're always on that bubble. So pre-contemplation. I'm not going to change anything, but we can talk. Or I don't want to talk. This is over. This meeting is over. So contemplation. Well, I'm considering change, but not right now. Let me think about it some more. We'll talk. Preparation. I've suffered enough. I think I want things to get better. Let's make a plan for change. Action. Change is tough, but I'm sticking with it. I could use more help to figure some things out. So again, it's that dynamic process that continues. And maintenance, hey, the plan is working, things are better, but now I have more to contemplate. Let's talk. So stages of change models. Evidence-based practices are very important in concurrent treatment, and the ones I have listed are especially pertinent for early recovery. So of course, it's important to assess pharmacotherapy needs for both mental health and substance use disorders, and providers need to have expertise in treating both disorders. Sorry? So due to the high risk for let me start over. Just assume if people with co-occurring disorders are in your office, just assume suicidality and the need to develop a safety plan, which is regularly reviewed. You just assume that. So assessments can often be difficult due to cognitive disorders or lack of trust. So there's important steps in the assessment process. And so a thorough history of suicidality as well as family history the same is important. And herein lies the problem at times. You have to make a concerted effort to gather as much collateral information as you can. So you're looking at maybe what's worked in the past and what's not. You need a full picture of this individual in order to decide how you go forward with treatment. So ongoing monitoring. So we continue to look at risk factors, positive changes, and any changes that might be needed to the treatment plan. There needs to be usually continued engagement with professional supports. So use of support systems helps to maintain and extend effective treatment. So that could be a number of things: mutual support groups, family, friends, providers, faith communities, etc. So supports include the development of intimate relationships, especially with other healthy peers in recovery from dual disorders. Co-occurring disorders. So you often hear a variation of a common theme. It's like, for the first time in my life, I feel like I belong. For the first time in my life, I feel like I'm connected, that people are listening to me. I no longer feel different than everyone else. And as one veteran put it, I don't feel like a freak anymore. So I thought that was unique. So what does recovery and remission look like? So it's important to remember chemical co-occurring disorders are along a continuum. What one person looks at recovery is might be different from another. For instance, some people it's like complete abstinence from mood-altering substances. That's the goal. Other people, it's like if I cut down in my frequency and amount that I drink, that's a successful in recovery. So the list is long. A lot of folks have kind of talked about it or whatever, but some people will always need ongoing treatment for co-occurring disorders. But the thing is, once treatment starts, the disease is no longer what defines the person as who they are. So this is my contact information. So I'm the mental health point of contact at the Fargo VA healthcare system, and you can call me at that number or email. Sometimes email is the best because I always check them, but I forget to look at my darn phone, But so if you have any questions about veterans and mental health issues or maybe anything, you can just give me a call, and that's part of my job. So I need to make a confession. I'm like the hair club for men. I'm not just a spokesman, I'm a member. So I have multiple co-occurring disorders. I've been sober from drugs and alcohol since 1985. Thank you. And I've been in mental health recovery since 1990. And the one thing I wanted to say to Cora's point, which she made earlier, I am here today and not dead because I had insurance, bottom line. Because I've dealt with suicidality kind of throughout the course of this. So thank you, Cora, for saying that. So I'll open it up to questions, and personal questions are okay. Have at it.
We have a question from online, actually a couple questions, Gerard. Would more than 2 disorders be considered co-occurring?
Yes.
Okay, second one.
So one is mental health, one is chemical dependency. So it has to be at least one of each to be co-occurring.
And I don't know if this would be directed to you, Gerard, or someone else. Can anyone speak or share experiences with eating disorders and suicide? Or chemical dependency, or any combination of the both?
Well, it's one of the things, the risk factors for developing co-occurring disorders, and it's also a high risk factor for suicide. I know that, but but I'm not an eating disorder expert.
Thank you.
I eat too much, that's my expertise.
Hey, Gerard. Hey, thanks. Just a quick question. Most of these recovery places that people go to, they're like 30 days only.
Right.
I mean, what's up? Why is that? I mean, is insurance companies?
So it's great. It's like, this is actually a 3-day thing that I put into 30 minutes, but so that's a great question and one I would address. So it's like, it's crazy, right? So
Yeah.
people, they can't think, they can't retain information, they're all over the place. So you put them in treatment for 30 days and they don't remember a whole hell of a lot about what happened in treatment, right? Because their brain is just getting functioning, So it's kind of that ongoing care. I think there should be longer, like residential stays and kind of a step down. So, you hospitalize for the acute disorder, you get people into longer term treatment, whether that's residential or some other form, and then they step down to IOP. And at the same time, they should be developing connections with 12-step support groups. So when treatment is over, they can step into that. And again, that's, there's more, it's more than just 12-step support groups, but that's really the model that the experts talk about, including the 12-step support.
Yeah, thanks a lot. But it seems like the missing link are the insurance companies.
Amen,
I mean,
brother.
they've got the biggest, tallest buildings in the world, and it makes me mad. I go out there and I see it all the time. People are suffering, and they're not doing anything. 30 days, it makes you mad.
Yeah, and I hate to complain about the state of North Dakota, so I'm not saying anything bad, but we just don't do a good job of mental health and substance abuse treatment. We don't. We have the resources, we're not putting them towards that. So
we got to keep the battle going.
Right on,
so thank
brother.
you.
Yep. Yep.
Okay, if you get 30 days for substance abuse, when you're suicidal, you get 2, maybe 3 days. And that changed probably, I know in the 80s, you were in for a month.
Yep.
And so now you're in for 3 days. I feel horrible when I help law enforcement do their job when they come and pick somebody up to take them to treatment, knowing that they're only going to be there for 3 days. Allison and I have talked about this before, and both of us feel like, I wish I could take care of this person in my own home, because I know they're facing 2 or 3 days. They're going to be kicked out. In my son's instance, the doctor told me the place was doing him more harm than good, and never talked to the family about how we could help him.
And one of the things I would say, Cora, too, is that, so I was involved in 12-step programming, 5 years in, this happened. And I got some bad advice from people in 12, I love 12-step programs, saved my life. But sometimes people don't know what they're talking about. Oh, if you use drugs, if you take those things, if you go to the psych ward, it's like you're relapsing. Bullshit, excuse my language, bullpucky. And again, if I didn't have insurance, I would have killed myself, but I was able to ignore everybody and go into a psych unit. I thought I was giving up, or that I was weak or whatever, but that saved my life. So without insurance, I wouldn't be here today.
We were actually getting ready to go to a treatment center in Chicago, because there is no treatment center in North Dakota, which with our numbers the way they are, shame on everybody.
Amen.
I heard they were, I was at a convention earlier this year and heard about, I think it's the Grand Forks area is working working on a program to where it's also sad to say it's veteran specific, but where they're offering the veteran the option of a treatment option instead of automatically going into the court system. So have you heard about that, and do you know if it's being worked on in other areas? Veteran
Drug Court I think is what you're talking about, and it's kind of an alternative, and there's actually been great success with that program, and that's the other thing that kind of makes me angry. We treat substance abuse and mental illness as a criminal issue rather than a mental, or somebody help me, public health, a public health issue. And so that's another one of the issues that really makes it difficult for people.
So regarding veteran-specific and the insurance issue, so I know some veterans are not eligible for VA care due to, dishonorable discharge status. Do we, from the VA perspective, I know you guys may not be able to touch them officially, what's the continuum of care at that point? Is it outside referrals or whatnot?
And I don't know enough about this, so I'm not going to, so don't exactly quote me on it, but there is an exception that's made. I think that veterans can get a certain amount of treatment for 30 days or something like that. And again, please don't quote me on that because I don't know the specifics, but there is kind of an option for people that, and that's pretty new actually. So,
that's not specifically for dishonorable discharges, but for other than honorable, there are exceptions for those types of discharges. And then there are exceptions also for people who don't meet the active duty service time. So my recommendation would be to contact Gerard or myself. If you've got somebody you're working with that says, I've been told I'm not eligible, because not only are there are those exceptions, but there's also ways to get them treatment that there wasn't in the past.
And bottom line is, it's kind of like, so if I have a veteran or I don't have any health insurance, whatever, and it's a one-time appointment, I'm going to reach out to the community and say, here's some options. Do you know what I'm saying? I mean, that's just the right thing to do.
Question from online: why isn't there as much emphasis on nutrition when dealing with addiction?
And that's one of the things that okay, let me get my thoughts together. So that's one of the things that isn't, but is important, but isn't addressed enough. Sometimes they say like, well, they're quitting, don't put so much on them. It's okay if they eat hamburgers and hot dogs, but that actually can set you up for relapse, poor nutrition, and there's another point I was going to make, but I forgot. I'm an old guy, you can tell, because I get lost in my PowerPoints and I don't know what I'm doing, and so. What's that? So my cards are in the back. So if you want to take one of my cards, go ahead. And there's a bit of stuff on stigma in the recovery model. I think is just helpful. Sometimes if you just put it down in front of someone and say, hey, here's the thing. It's not about you're being ill. It's about a whole number of other things, and we got to treat the whole person.